advancing perinatal mental health care through the MTPAL line. And I am delighted to welcome Dr. Megan Verlage to the stage with us today. So Megan is a board certified general adult psychiatrist with a specialization in women's health and focusing on psychiatric issues related to pregnancy and postpartum, as well as a variety of other women's health specific conditions. So with that, I will welcome Dr. Verlage to the stage. I think I need to make you a co-host real quick.
All right.
Okay.
Objectives for this presentation. I was told that one of the main goals was so that you guys had a familiar face when using our consult line, which I'm going to talk about in a little bit. Just so that, again, you guys know my face, who I am, and start using this resource more, hopefully. Other kind of topics that have been popular to discuss, and so we're going to do that today, is talking about bipolar disorder in general, bipolar disorder during pregnancy, ADHD in general, and ADHD during pregnancy and postpartum, along with some basics of how we think about things that we need to think about when we're working with patients and treating psychiatric conditions during pregnancy and postpartum. So I don't think I've ever made a PowerPoint on myself, but here it is. So I grew up in Mexico for 18 years, actually, and yeah, largely in Guadalajara. So then I went straight from Mexico, did my undergrad in the US, went to medical school at Ohio State, then did my residency in Dallas, Texas at UT Southwestern. Very fortunately for me, they had a kind of built-in specialized track in women's mental health. I was very on the fence. I almost did my residency in OBGYN, but I'm very glad that I did not. I love psychiatry. But this was a perfect balance of the two. So yeah, got some specialized training during residency. And then I stayed on staff at the hospital where I trained for a year, working in the ER. Lots of experience there, lots of interesting stories, as you can imagine. But then after that year, I moseyed back to where I did medical school, where my spouse is from, in Columbus. And so I opened a private practice here and then started working initially part-time, but now full-time, so 3 days a week, with Frontier Psychiatry. That's where the Montana connection comes in. They're a Montana-based company. And then that's how I got connected with the consult line, which is now called the MTPAL line. I'm going to talk about that in a second. So yeah, that takes up my week. And other things about me is I'm a jock at heart, so long sports history. The one that I have the most history with is rugby. I started that in college and did that throughout, did a little bit of, you can imagine there aren't a lot of Mexican rugby players, so the pool's pretty small, but got to play with Mexico for a couple of summers. And then since I can no longer take the risk of getting concussed and not being able to work, I've moseyed into different things. So I do CrossFit, I like to bake, and I'm a mother of 2 boys. They're there on the top. So yeah, all those things keep me busy enough. All right, so I wanted to start the presentation with a clinical case that is actually from the consult line, to kind of open, how things that we're going to discuss and things that we need to think about, and a very real example of, again, what this looks like. So this patient is a 31-year-old female. She's got a history of depression, anxiety, and PTSD. And she is 9 weeks pregnant. She's not taking any of she's not taking any psychiatric medications, and she's had real issues tolerating psychiatric medicines in the past. So she's with her nurse midwife, and her midwife is, she's telling her about her depression. And then when this very astute midwife reviews her history, she is concerned of the patient possibly having bipolar disorder. So now isn't super sure about how to proceed. So that brings us to talking about the consult line. So I've alluded to it even a couple of times in the few minutes that we've been on, but it was recently rebranded. So it used to be the Prism line, and now it's called the MTPAL line. And basically the rebranding had to do with joining kind of what I do, working with pregnant postpartum women and the pediatric consult line into one title. So that's why the rebranding, which was this year that happened. And the main thing that we do is work with doctors, nurse midwives, a lot of people who prescribe medications, helping guide them through, making medication choices and diagnoses. But we also work with other, members of somebody's mental health team. So case managers, social workers, if you would like to discuss a case and try to figure out diagnoses or, some help with crisis planning management, this resource can also help with those kinds of cases. So let's jump into just general principles about thinking about treating women, any bipolar, ADHD, or other mental health conditions during pregnancy. So, and this is a lot of what I have to counsel patients on, or what I'm going to walk through in this slide. So the first concept is that so the best type of data we have in medicine and in science is what we call randomized controlled trials. So in those kinds of trials, we have a group that gets the medicine, the intervention, what have you, and another group that gets the, placebo, sugar pill. And what we do is we watch what happens, we compare, okay, did one group do better than the other? Did one group have problems versus the other? Just to help guide us in terms of what is actually effective and what the risks of these interventions can be. Now, when we think about pregnant women, we have to pause. It's not ethical to give a group of pregnant women something new and say, is this going to cause problems in your baby? So what we're left with is, or when we take women who, for whatever reason, had to be on a medication during pregnancy, and we pull together the data and we try to see, do we see any red flags? Do we see any issues? And when we've got a big enough pool, we can say, there's no red flags, there's no clear issues with the medicine, and we can move forward and use it. And we're always working on increasing that pool of data. So that's one consideration, is again, we're already working with not ideal data. Another thing to think about when I'm talking to a pregnant woman is where she's at in her pregnancy. So the risks are different to consider depending on, what week of pregnancy they're in. So from this graph, you can see that when we're thinking about malformation risk, that first trimester, those first 8 weeks, or again, even earlier than the end of the first trimester, are really where we would see issues with major malformations. And so I have women who will opt to hold medicines during that time and then try to, introduce the medication back later in pregnancy. But, the counseling I'm going to do if they are in their third trimester, discussing malformation risks is not as pressing of an issue, again, because those happen, if those happen, those are going to be mostly in the first trimester. There's always important to bring up that there is always a baseline risk for teratogenicity or malformations with any pregnancy, regardless of if they were on any medicines or not, and that's 2 to 4%. So, regardless of how the outcomes come, kind of setting that precedent and that expectation that can always happen. And so, when we're discussing risks of medications and possible teratogenicity, there's always this baseline risk to think about. And I'm going to talk a little bit about this in future slides, but we think a lot about the risks of malformations. Yes, that is one of the factors to consider when we're thinking about what's going to be best. But another really important factor is, depression, uncontrolled bipolar disorder, uncontrolled ADHD. Those also carry risks. So, if mom is having any of those conditions and is not eating as well as she normally does, is not sleeping as well as she normally is just not functioning as well, those carry risks too. So baby usually does best when mom feels good. So really kind of changing the framework of these moms thinking that them continuing treatment, continuing to manage their conditions as putting their baby on the back burner, putting themselves first, is really not how we think of it at all. They're both the same. So us prioritizing mom's mental health is what's best for baby. And I spend a lot of time kind of getting moms to this point of understanding. So those are some, again, very general principles about working with pregnant women for any condition. So let's talk about bipolar disorder. And again, this was a hot topic for my presentation back in the summer when I was in Bozeman at one of these conferences. So there's, for our diagnoses, at least what we have in our DSM currently, there's bipolar 1, bipolar 2. I think there's more of a gray between bipolar 2 and some other conditions. Bipolar 1 is considered the more severe type, and a lot of times ends in a patient being hospitalized. So again, maybe a little clearer cut. But so when it comes to mania or hypomania, mania being bipolar 1, hypomania being part of bipolar 2, there's a lot of overlap with different psychiatric conditions. So people who have really bad anxiety and aren't sleeping, racing thoughts, you can imagine overlap there. A big one is trauma responses, or people who struggle with personality disorders. They get these, events that can look and be as severe as mania or hypomania. So where do we draw the line and how do we figure this out? The things, and this is how I usually start with screening for if somebody's had mania or hypomania, is something that's very unique to mania or hypomania and not to other conditions, is there's a discrepancy between the sleep and energy, where you have somebody who's not sleeping, their energy may be high, maybe 1 or 2 days from just adrenaline, but it's not gonna last very long. Versus somebody who's going through mania or hypomania, they're gonna be sleeping less or not at all, and their energy level is much higher than what it normally is. And that the sleep issues are in almost every case of mania. So it's not like, well, in some, it's very hard to find somebody who's experiencing mania or hypomania who does not have some kind of sleep issue or disturbance. So that is one very helpful way for us to figure out, what to hone in on an accurate diagnosis. Another thing to watch for, and this is not a hard and fast rule, but when we're thinking about some other conditions, a lot of times those are triggered events. So a very difficult conversation or an argument with a loved one or partner, something very tragic happening. When there's some kind of very clear inciting event leading to behaviors that can resemble mania, that can be another way to, figure out if it's maybe something else over mania or hypomania. And then kind of asterisks, it has to be in the context of not using substances. The ones that can largely resemble mania or hypomania are stimulants, either be illicit stimulants or prescribed that are being used not as prescribed. Both of those can trigger it. Having worked in the emergency room, they look pretty identical. And the only way we would know, if say they were refusing a urine drug screen, the only way to know which one it was is to give them some time. You know, if they came down after a day or two, it was substance, and if not, it's mania. So just to, yeah, describe how similar they can look. So yeah, it's only mania or hypomania if it was not triggered by, you know, substances. So that brings us to kind of thinking about, once we've established a diagnosis, thinking about the risks specifically for pregnant women. So understandably, and you know, obviously, mania comes with inherent risks and behaviors. So, you know, they're going to be more impulsive, but I've seen patients who, you know, have gotten shot because of behaviors, who've walked for miles without shoes on, you know, just these things that can really put them physically at risk. So that's, you have, you know, a woman who's pregnant, and now, you know, the person themselves is at risk. They were also kind of more physically vulnerable because they're pregnant. And yeah, now we have another life to consider too in the equation. So definitely, you know, we know that severe and even, you know, mild to moderate cases of mania during pregnancy can lead to some real, you know, outcomes that are not ideal and dangerous. So then for other, so those are maybe a more obvious risk, but there's other risks too. Kind of like for both depressed patients, again, bipolar often comes with, you know, depressed episodes too, but depression and mania can lead to moms struggling to eat well, sleep well, go to their doctor's visits, take their prenatal vitamins or other medications that they, you know, have been prescribed. Those things are all going to be compromised. And again, this kind of ties back to what I said before, is mom feeling best is what's best for baby. Mom feeling best means she can do all of these things. And again, kind of, I mentioned this too before in this last bullet point, is that we know that uncontrolled depression, uncontrolled anxiety can lead to early birth, low birth weight, and some other, you know, poor outcomes that are not ideal. So those are really real risks and very well researched and documented risks that come with uncontrolled psychiatric symptoms during pregnancy. So this graph, I think, is one of the most jarring or just like memorable graphs I saw through residency in any paper. And it has to do, so on the y-axis, the, you know, the top means that those are women who say don't have any mood episodes. No depression, no mania means that we would see a flat line. And then time goes on at on the bottom. So 40 weeks, the length of pregnancy. And obviously lower on the graph means that there was some kind of mood episode, be it depression or mania. So the purple line is women who actually continued treatment, and orange is that they discontinued treatment. So for so many reasons, but we know that bipolar disorder is a very, very fragile time for, you know, for these patients. As you can tell, even women who continue medication, there is still a third of them are going to have a mood episode. So we have to keep a close eye on them, let alone if they stop treatment. I mean, we're at 20% or 80% are having some kind of mood episode. And we just kind of reviewed all of these risks that comes with, you know, mania and depression and those poor outcomes on the pregnancy. So just to, you know, highlight how important it is for us to really watch these patients and figure out a treatment plan for them, and the fact that they need to be on some medication, because it can very easily and probably lead to poor outcomes. So the treatment for bipolar disorder is a mood stabilizer or a second generation antipsychotic. The importance of establishing a diagnosis, an accurate diagnosis, is so important, because if you say called this a or a major depressive episode that is major depressive disorder, you treat with an antidepressant. But in a bipolar patient, those medications can actually trigger mania. So yeah, you can imagine from that nurse midwife's perspective, trying to figure out what to do next can be really challenging, because it's a tough condition, because if you treat it wrong, it can lead to some really, serious effects. So the other kind of very frustrating thing is that there's, I'm not going to say misinformation, but not a complete picture of information that a lot of practitioners learn about mood stabilizers during pregnancy. So I think back to when I was in medical school, and the big thing was, oh, lithium during pregnancy causes Epstein's anomaly, which is a heart condition. And so, that's what gets glued in people's brain, and that's just the precedent. So you can't use lithium during pregnancy, right? And that is not accurate. And actually, that kind of principle applies to all mood stabilizers. I've had psychiatrists and other providers ask me, like, oh, well, I have a bipolar patient, so I can't use any mood stabilizers because they're all going to cause malformations. And again, just to emphasize how, incorrect a lot of people's understanding of these medications for pregnancy is. There is one exception, which is Depakote. We usually get off of that one, but outside of that, most of these medications you can use during pregnancy. An important piece here to understand why there's this misconception is a difference between the relative and the absolute risk of, some of these medicines. So take lithium, for example. So the baseline risk for any pregnancy to have some kind of heart issue is 1%, or 1.1%. And then if they take lithium, it increases twofold, a little under twofold, to 1.9%. But the absolute risk is still very low. So yes, it's doubling the amount, but we're still talking one more out of 100 women who were treated. So, and we think about all the risks of somebody becoming manic or depressed. I have, some colleagues in perinatal psychiatry who will actually pick lithium first because it works quickly. We can monitor levels. And again, the absolute risk is still very low compared to the real risks of uncontrolled mood episodes. So I've already kind of harped on the fact that we need to keep a very close eye on bipolar patients during pregnancy, even if they've been stable for a long time. And another part of that, and part of what leads to these mood episodes, is blood volume. So that changes a lot during pregnancy. And so the same dosage that's kept them stable for a long time may not be getting in their system enough because they have a lot more blood, or a lot more blood volume. So, we need to be very proactive about changing those medicines and increasing them if necessary. And it's often a thing we have to do. Okay. So, I frustratingly don't have a graph like the one we just saw, but the postpartum period is either equally or even more risky for bipolar patients as during pregnancy. So, you throw in the fact that mom now has a newborn that she has to get up every 2 hours to feed, and that, lack of sleep is a real problem that needs to be planned for. So sleep is important for everyone's wellness. Sleep, we should talk about it and prioritize it. But for bipolar patients, half of their treatment is medicine and half of it is making sure that they can sleep. It is like a medical indication that they need to sleep. So, I like to try to plan ahead for them to have some kind of system set up that they get 6 hours of uninterrupted sleep. Which again can be very challenging. And a big part of that challenge is breastfeeding. So that brings me to kind of a peeve of mine in where the culture is right now. So, I am super sensitive to be very supportive of whatever mom's goals are. And if breastfeeding is one of those, and, only breastfeeding is that goal, then we will find a way or figure out a way to make that work. But I do think that the pendulum, at least in, new mom culture, has swung way too far, and that, if you do not breastfeed, you are not doing what's best for your baby. Having experienced that personally when I was delivering and in the hospital and with all the people coming in and what they're telling me. So, I think normalizing that, there's a lot of physical reasons why women can't breastfeed. There's a lot of logistical reasons why women can't breastfeed. And that's perfectly fine. And their baby's going to be perfectly healthy. And so mom guilt already starts way too early. So let's pull back on that and normalize that it's okay to partially use, formula if needed, if not entirely, and that all of these options are healthy options. And we're going to do the data about breast milk is one piece of the puzzle, but there are so many other factors to consider. So I definitely like to have that conversation with all my moms, but especially, patients with bipolar disorder, where, introducing some formula to help with these, the sleep cycles and getting this dedicated sleep, is part of the conversation I like to have with them and see where they're at. So yeah, let's see here. So let's go back to the consult that I started with. So I talked with this nurse midwife. On reviewing the history, it did seem that she had episodes that were concerning for mania/hypomania. She had gone, a couple of weeks with minimal to no sleep, while having energy. People were telling her that she was talking fast. She took a couple of unplanned trips with no plans of where she was going to stay. That's one that we'll hear often. And then she impulsively bought surfboards in Montana. So you can imagine that didn't make a lot of sense. So enough there for us to say, okay, we feel confident that it is bipolar disorder. So we're going to avoid antidepressants/SSRIs until we get a mood stabilizer on board. She had previously tried lithium and Zyprexa. Again, she was having difficulties with side effects. Those can be a little bit heavier on the side effect profile. So we talked about some alternatives, the mood stabilizers that have a little bit more data. Again, that bigger pools of data for use during pregnancy, being lamotrigine, quetiapine, and Abilify, and walking through dosing and counseling for patient on those options. And then again, emphasizing that this mom needs to be watched monthly and being proactive about increasing doses of any of these medicines if there are breakthrough mood symptoms. So that was that case. So let's transition to the next topic, which is ADHD. That one, again, brought in by popular demand. So having practiced over the last 5 years and seeing this kind of crazy uptick in people presenting, wondering if they have ADHD, I do think social media is playing a very big role. Even just getting this picture online, there were so many options of things to screenshot of TikToks of people making things about ADHD, and what that looks like. So it's a double-edged sword. I think there's, on the one hand, we're diagnosing and catching cases that wouldn't have been caught otherwise without more visibility. And so they're getting treatment, and that is excellent. But on the other hand, we're getting cases that maybe aren't ADHD, and kind of exposing women or people in general to medications that aren't necessary and that come with some real risks. So these risks, all of our medications have risks. Stimulants have some more risks than the rest. They are considered a controlled substance. They have, an addiction potential. They have heart and cardiac risks. So, we have to be really mindful about what's the best thing to do moving forward when we're trying to help the most amount of people while not causing harm. A big piece of these evaluations is figuring out, is it a comorbid condition? So anxiety, very much has similarities with ADHD. So making sure it's not that, making sure depression isn't going on. Again, if you look up in the DSM, the criteria for anxiety and depression, issues with concentration are in there. So that's very real. If someone's not sleeping, I see this a lot actually, is they're sleep deprived. Of course they can't concentrate. Another big one is, marijuana use. I've got, if someone's using marijuana every single day, you can believe that their cognitive abilities are going to be affected. And so, personally, I, require patients to be sober from marijuana before we consider starting a stimulant or assessing for ADHD. All of this being said, is there's no real consensus about how to do this right amongst psychiatrists on different forums. People are very opinionated and there's different, considerations. So on the one hand, you've got psychiatrists saying, we are prescribing medications irresponsibly and there's going to be real harm from this. Another one saying, well, ADHD is one of the most underdiagnosed, untreated conditions, and we need to, listen to patients and treat them. So, what I'm saying today is my opinion, but it's definitely not, I can't speak under the flag of this is what everybody agrees on. Fortunately with Frontier, they have like a cognitive screening test that will show certain patterns that can be consistent with ADHD and can help with the accuracy of, the diagnosis. Now, I've got colleagues who require kind of the full cognitive testing, which is neuropsychological testing. It takes 4 hours to do, got to get it approved by insurance, usually months of a wait list before you can get in. So, how long do we leave patients untreated before we kind of move in? Again, it's a lot of gray. I've changed how I approach it, and kind of this is where I've landed, is again using the screening test and going from there. But yeah, I think if we fast forward a couple of years, hopefully we'll have a better answer of how to get more accurate diagnoses and, hence can just treat, more accurately. So let's say the person has ADHD. So the rest of the presentation will be with the assumption that this is ADHD. What do we do for treatment during pregnancy? So 5 years ago, I remember it was like one of my last years in residency, and we were trying to answer this question of like, can we use these medicines? And the only data that was out there was for women who were using illicit stimulants like cocaine and methamphetamine and the outcomes of those. So you can imagine that there's a lot of confounding variables for that, population. And then and it's also not the same substance. So, much, much more potent than prescription stimulants. So, but that was because that was all that we had, and we knew that it had bad outcomes. The answer was no, cannot use during pregnancy. Fortunately, better psychiatrists than me have been working on pooling enough data to give us the green light on using them. And we've gotten to a point that we can, very fortunately. So, we won't have to go into too much detail about what, these exact studies were, but pools of data. One of them looks specifically at teratogenicity. So, and the one place where there did seem to be an uptick was in cardiac issues. So again, we have that 1% baseline risk for cardiac issues in any pregnancy. And that did increase to 1.7% for if women, or if the mother was on a stimulant. So there's, and again, thinking about absolute risk versus relative risk, it's an increase, but we're still talking a pretty low number overall. Another study looked at neurodevelopmental issues, autism, and didn't find any correlation there. So again, largely reassuring. The other research that's been being done is, we've got a lot of data about stopping, about the bad effects of depression and anxiety on a pregnancy, but we also have more data about untreated ADHD during pregnancy. And, no surprises is it puts mom at more risk for a depressive episode, for bad anxiety. And then, I think they described it as moms just feeling overall disconnected from their families. It was impairing their ability to function as their role in the family unit. And so, we already know that those issues cause problems in pregnancies. So, vis-a-vis untreated ADHD also has some, negative outcomes if not being treated. There's also like the more severe, people with ADHD are more likely to have car accidents if on the, again, more severe, and can have car accidents and other issues like that. And those are real risks too. And then, yeah, so generally speaking, with the pools of data that we've got now, the what we agree on is moderate to severe ADHD, we recommend continuing treatment with the stimulant during pregnancy. Mild cases, sometimes we can get away with therapy and other options. So if we have, which now we've got more data, still could use more, but we definitely have very little data about stimulant use during pregnancy. I listed here the little bit that we have. Overall, from the couple of cases that we have, we do see that it's excreted in very low amounts into breast milk. And then, so either, and in babies, it's either undetectable or at very low amounts, and no issues that we can see in infants themselves. So generally speaking, we think of the higher risk period of medicating is pregnancy. Breastfeeding is overall, this is not hard and fast, but risks during breastfeeding are going to be lower overall. So same kind of principles. If mom's got moderate to severe symptoms, we do recommend continuing the stimulant during breastfeeding. Now we can get a little bit fancy with it, where we can try using immediate release versions of the medicines, which gives us the flexibility of only using it when absolutely needed. Say mom just needs it, at work and she's fine otherwise, then we can use an immediate release that will just be in her system for those couple of hours instead of all day. The other thing that allows us for is, they can pump or breastfeed right before they take the medicine, and then the blood volume or the amount of medication in the blood is equal to the amount in breast milk. So you can imagine, as we wait for that level to come down in the blood, it means there's going to be less in breast milk. So when baby, breastfeeds next time, hopefully that will again come down to a lower level. Sometimes that's tough to, coordinate logistically if I take it or I don't take it, but really motivated moms can have that option. So yes, let's see here. I think that was my last slide. So I will open the floor to any questions. There we go.
Great. Thanks, Dr. Verlage. We do have a couple of questions in the chat. So first one, when someone is using ADHD medication and also heavily using caffeine or caffeinated drinks, but not taking that medication properly, what's a good way to bring this up? If you're noticing manic behaviors or some such.
Okay. That has multiple levels to it. So
many layers. I'll let you peel them back.
Yes. So the first piece is the caffeine and stimulants. It's fine to use both of them. I usually tell patients that if they're starting a stimulant, I will have them hold any caffeine and then introduce it later to make sure that they tolerate it, because if they're getting hit with both, there's a good chance they're going to get jittery. But I wouldn't say that you can't use both. They're like contraindicated together. Yeah, there's some people who feel pretty strongly about their caffeine. And then the next bit was if they're becoming manic on a stimulant, maybe. If they're manic, you need to stop the stimulant immediately and caffeine. So that is going to be, the offending agent to them becoming manic. And so they're going to need some kind of medication to bring them down. But step one is stop the stimulant. That's gonna, that'll only make things worse and keep fueling that fire. So, and in the future, I mean, when people ask me what my most complicated patients are, I think of patients who have bipolar and ADHD, because again, those ADHD meds are just, again, fueling that fire of making them manic. I've got patients on both, but it has to be very, we get there carefully and with close monitoring. So you think you have a patient who's manic and is taking a stimulant, you stop the stimulant and caffeine first, for sure.
Thank you for that. Another question was, do you notice medication doses need adjusted during pregnancy and then again in that postpartum period? And how do hormones impact with the blood volume? Just talk a little bit about how you adjust meds.
Yeah. So absolutely. Blood volume increases and we are proactive about increasing doses, even if it's above, the recommended or guideline or the maximum dose, you can go above it. And that happens quite often during pregnancy. They're getting less of the medication because their blood volume is so high. Now that usually doesn't happen until second, third trimester, but it does mean that even again, if your patient's been stable for a long time, you need to follow them monthly and or have a plan, tell them, if you notice your symptoms come back, let's not kick that can. Let's be proactive. A lot of our medications take a while to start working. So I tell them, increase your dose if you notice anything, because it's something that happens a lot and physiologically we can almost expect. Now, I don't, and most providers would agree, we don't do it preemptively saying, oh, well, your blood volume is going to increase, so let's go up now. We do it largely symptom based. So if the symptoms break through, then we follow it up with an increase in the dose. Hormones absolutely play a huge role here. And it's one of the reasons why we think that from that chart that I showed, the risk for a mood episode is so high, is physiologically, try to predict hormones and they'll show you. But yeah, it's definitely a consideration. And for transitioning from pregnancy to postpartum, there's, especially if you've increased it because their blood volume went up, so you had to go up on the dose, what I normally do is I wait a month, just because postpartum is such a high, hormones are changing a lot. And that first month is, higher risk for a mood episode relapse. So I will, barring some medications like lithium, we do have to be a little more proactive about backing off of, but I'll usually keep the medicines on board, meet with mom 2 to 4 weeks after she delivers. And then if they're looking stable, no obvious symptoms, then we can back off of the medicine to a lower dose. But if they were on that dose throughout their pregnancy, we didn't have to go up chasing the blood volume and breakthrough symptoms, then I'm not going to lower the dose after delivery. That was maybe a little bit of a long answer, but yes.
No, I think it's super helpful, just that nuance of when and how and when to know. There are some prescribers on the call today, but they may be viewing the recordings later, but it's also a lot of individuals who are, accompanying these patients through this and are really trying to also make sense of changes in prescribing protocols and, medications and different things. So it's appreciating to have that kind of nuance. We had a few more questions. Does the efficacy of medication change if it's stopped and later restarted? So thinking about folks that maybe have hesitation initially with, taking medication during pregnancy particularly, and then, when they engage with that or decide that that's maybe what they do want to do, is there any change in efficacies of medications there?
So I complain about psych meds for so many reasons. They take a lot of times forever to work and other things, side effects. The one, I guess, grace that they give us is that if somebody's responded to the medicine before, even if you stop it, it should work just as well the next time. Now, sometimes I've seen plenty of women who postpartum, whatever hormonal changes happen and physiological changes happen, their medicine stops working as well for them. So that's a little bit of an exception and a niche. That is not 100% true. And if I have somebody postpartum who said, I did great on this other medicine, that's the first one I'm going to try. But it gives us the flexibility. This is just practicing in general. If I have a patient who's been stable for a long time, I can feel pretty confident. Let's try to see how you do off the medicines. And if it stops, if your symptoms come back, going back to the same medicine should work just as well as before. So generally speaking, yes, the medicine should be just as effective, even if you come off of it and get back on it.
Great. Thank you for that. I think that's probably reassuring for some folks.
Yeah.
Yeah, another question. Do symptoms of ADHD increase or become more apparent during pregnancy or postpartum?
There's some data about premenstrual ADHD breakthrough, perimenopausal kind of ADHD symptom breakthrough. I'm not familiar with pregnancy and postpartum, but what I will say is that, if somebody is a new eval, like I'm seeing them for the first time and they are reporting symptoms of ADHD and they're pregnant, I normally will not start testing treatment for ADHD on a pregnant patient. So, this is not to be dismissive of symptoms at all, but there's a chance that it's not the right treatment. There's a chance that we're going to have to switch medicine. So there's a very good chance that we're going to be risking or exposing mom to unnecessary risk by chasing that. If I would really lean on whatever's helped them function this long to continue it. But that's a little bit of a niche that's tough because, if these other hormonally based conditions are causing upticks in ADHD, it could very well happen during pregnancy. The problem is during pregnancy we're now thinking about exposure to, the baby, and usually not my practice to start finding the right treatment for ADHD with medications during pregnancy.
Yeah, then, I think that really drives home the need to have, the psychiatric consult line and to be able to bring in multiple opinions, even, as a prescriber or a long-term practitioner to be able to get that consult piece of the puzzle. So I appreciate your thoughtfulness in answering these.
Of course.
Yeah, I think last question here. So, and this is a great question. So, how do you identify when postpartum depression is being mistreated with an SSRI that is causing mania? So, the patient reports having more energy, but it could be mania. How do you know when postpartum depression is just that, or if it's undiagnosed bipolar? So going back to, that idea of like, how do we tease these things apart? And if you are a person who's maybe not the prescriber in this scenario, but maybe sees that patient or client more regularly than even the prescriber does, what are some of those telltale signs that, oh, yeah, nope, we're mistreating. This is not diagnosed.
Yeah. And you can imagine that women have difficulty sleeping. I love the statement that's like, oh, sleep when the baby sleeps. And I watch this TikTok of people who are just the baby's you're in the stroller and then they just sit on the sidewalk and sleep, or it's just, practically not feasible a lot of the times. And so then these women are having difficulty sleeping. But the biggest thing is you ask one of those women who's having difficulty sleeping, and she is going to be so tired. So that's where, again, it's, and a lot of time anxiety upticks, depression upticks, these racing thoughts uptick, which again can resemble mania. That discrepancy in the sleep. So, I can't sleep and I have lots of energy. And if that lasts 1 or 2 days, that might be, again, some kind of stepping up to the plate, adrenaline rush, but mania is going to be 4 more days. And, I think the big difference is, again, moms are going to tell you, I'm not sleeping, but I'm really, really tired, or they're not. And then if they're not, who knows if they're just super women, but exploring those other symptoms of bipolar disorder. Well, first off, just by looking at them, do you feel like they're talking really fast? Do you feel like kind of what they're saying is disorganized and not really streamlined in what they're trying to communicate? And then asking about impulsivity. What have you been doing since you're awake? What do you do when that happens? A big one people will say is cleaning, which is, that's a great one. So maybe some manic people clean, but if a lot of people are not able to sleep, they're going to try to be productive and clean. So, but something that's just like, that's really odd that you would do that. That's the kind of thing that we're looking for. And again, not even something you need to explore if somebody's saying, yeah, I'm not sleeping, but I'm really tired. I usually just leave it at that and say, this is something else. It's not mania. But yeah.
Awesome. Thank you so much for that, Dr. Verlage. And I just, want to go back and say, confirm with you that, many of us on this call are aware of the Prism for Moms line, and that's been here, but folks, know that that line that you've got on a magnet, the phone number to call, the website, the address is there, those are all still live, and that's how you can access Megan or Dr. Verlage and get some more of this consult assistance as well. So just know that there's continuity in this service, and while we may have different brands at this point, we really, are seeing that this is something that's still accessible, it's still valuable, and we hope that you all will continue to access the supports of Prism through the MTPAL process and branding. So thank you very much for this, Dr. Verlage. With that, I'll say anybody who has more questions for Dr. Verlage, please throw those up in the Whova chat or Q&A sections. And we ask all of our presenters to come back and answer those questions in the weeks following when folks are, maybe slow processors like me and think about it the next day or are viewing the virtual recordings. So know that will happen. With that, we're coming to the close of our time together today. I want to thank you all for being present here today and making time to continue to improve the care for families in the perinatal period in Montana and beyond. One key thing I want to end with is some gratitude for our sponsors. We have incredible partners and sponsors at Department of Public Health and Human Services, in the Injury Prevention Bureau, and then also our friends in the Health Resources Division, better known as Medicaid, who are the sponsors for PRISM as well. So thank you so much for those sponsors. I encourage everybody else to check out the webpage to see the full list. I appreciate you all for that. And please know that recordings for today's sessions will be processed and posted throughout the week and will be available on Whova for 3 months. We've decided to extend that out beyond what we generally do, so you'll have up until January 15th. We will likely send out some reminders to those of you who have access to those recordings and presentations throughout that 3-month time period to just ping you that you still have those resources at your fingertips. All of the presenters have been wonderful and shared their slides with us, and those are also available on Whova. So continue the connection in that space, and I want to thank you all for all of the work that you do to improve the lives of moms, babies, and families in the state of Montana. Thank you so much, and with that, I hope you have a great day.